Good afternoon. Can you see the slides?
Yes.
Okay, so perfect. The aim of this presentation is to briefly take into consideration the main dimensions related to the treatment adherence, and also at highlighting how improved adherence to treatment is really important, especially for connective tissue disease. In order to do that, this presentation will range from the basic definition of adherence to treatment and the weight of the problem also in general chronic diseases and some data regarding connective tissue diseases to the potential innovative approach that we may adopt in exploring adherence to treatment in research, in clinical research. And finally, the presentation will end with practical instructions, a sort of 5 key points useful in clinical practice in order to improve from the side of clinician and from the side of patients treatment adherence. But what does treatment adherence mean? Basically, adherence to treatment describes how a patient follows an indication, a recommendation, something prescribed by the doctor, but actually is more than prescribe and taking a drug. It's something related to behavior of the patient, of the subject, and something related to taking drugs, but also other therapy, following diets, or try to change lifestyle. So it is really important, and it is related to different dimensions of the life of the patients, not only the diagnosis of a disease. Unfortunately, when adherence to treatment is low, it is related and associated to poor outcome for basically each diseases that we have to treat with drugs. And it is associated with a poor quality of life and an economic impact on the healthcare system as well. There are different approaches in terms of definition of taxonomy of what the dimension of adherence to treatment are defined. And WHO has defined some years ago, 2 decades ago, some macro area related to adherence to treatment. They are obvious macro area, and so no definition, strictly definition to adherence to treatment, but we may consider this area something that we should consider in our disease in approaching adherence to treatment. First of all, the condition. We are talking about adherence in general in this slide, but when talking about our disease, connective tissue disease in general, autoimmune disease, we know that conditions are different. They are many aspects in common, but many other aspects are so different. So the condition, there are condition-related aspects that can be very important. But there are also patient-related aspects. A subject is different from another subject. We are all different people, and we may approach to a diagnosis, to problems in real life, or to taking the drugs in a different way. But there are also problems in terms of therapies. So we have in the rheumatological field many therapies, and there are different routes of administrations. And we know that different therapies mean also different approach and different potential problem related to adherence to treatment. But there are also problems in terms of socioeconomic burden of the disease, and by definition also for the drugs. And also problem related to the healthcare system, not only problem. I would say the dimension of the healthcare system, since healthcare system means in terms of adherence to treatment, the team, the doctor that is taking care of the patient. But we should consider that in terms of adherence to treatment, we can distinguish between 2 main big aspects: intentional, low or non-adherence, or unintentional. obvious in the same person. Both approach, both reasons can be present, not only in the same person, but also in different times of the life of the disease. And for example, intentional is related to design, specifically decide to omit a dose, a drug, and for some specific reason. Unintentional approach to non-adherence is, for example, forget for no specific reasons. But in practice, should we consider adherence to treatment something challenging? In other words, is it really a clinical problem? Unfortunately, yes. And the WHO consider medication adherence something that may have a higher impact on patient outcome than the treatment itself. I know that the sentence is very substantial, but it is the reality, since if we have a drug that can work in the disease and the drug is not taken in the correct way, obviously the outcome is poor. So WHO consider adherence to treatment something very, very important, more important than the treatment itself. But taking a look to the chronic disease in general, there are a lot of data, growing data regarding non-adherence rates, and surprisingly, also in high prevalence disease, there are data demonstrating that non-adherence rates are very, very high. And for example, there is a very significant study, a Canadian study that assessed non-adherence in basic treatment for hyperlipidemia or hypertension or other high prevalence disease. And as you can see, 31% of these treatments were not adherent, the subject and the treatment itself in the different dosage in 9 months. So it is a very significant data. But regarding our field, rheumatological field, more specifically, there are data, recent data regarding the exploration of the different potential reasons of this no or low adherence. And the question for the group of Potrel and the other co-authors was, is it a matter of route of administration or a pain-related disease? So they compared, for example, something pain-related, by definition, rheumatoid arthritis, to other diseases, non-pain-related, such as dyslipidemia. And unfortunately, the answer is no. So they did not observe any significant difference in terms of pain or non-pain related disease. So treatment adherence is more complex than we may think or assume. But we may consider that as many aspects in the drug, in a diagnosis, there is always a multidimensional phenomenon. And it is strongly related to our disease, since we know that autoimmune disease, connective tissue disease are something that we should always take into account in a multidimensional way. First of all, we have to consider that physician-patient relationship is essential in improving adherence to treatment. But we know, as WHO has stated, patients' characteristics are very, very important. We know also that administration routes are important, and we may discuss when choosing a therapy which kind of route is more likely to be adherent for the patient. The treatment efficacy and duration is also important in our disease, since we know that our disease are chronic disease, and someone said a diagnosis, a rheumatic diagnosis is forever. So also the treatment is forever, and it is really important in terms of adherence and the approach to the drugs. But obviously, patients' empowerment in the whole definition of empowerment that we may assume is really, really important. Obviously, this challenge is really important for connective tissue disease in general. Why? since we know that connective tissue disease are always characterized by a lot of challenges, the diagnosis, an early diagnosis, differential diagnosis, and many other aspects related to a chronic disease. The relapsing and remitting course of the disease, and in many cases, remitting course, remitting phases may be associated to a low adherence for many reasons. There are different expressions in terms of phenotypes, also in the same disease. There is the concept of the rarity for the rare condition in connective tissue disease, but there is also the concept of complexity. This is the case, for example, in lupus or systemic sclerosis. And there is also a big problem that in many cases, and there is something that ERN, the duty to fight and to make more homogeneous the off-label use of the drugs that is different in different countries and is different in different regions of the same country. So it is also associated, not only in terms of patient's perspective, but also in terms of bureaucracy in low adherence. There is also another big problem in our connective tissue disease that in many cases, when a drug is not working, we not always know if the reason is no response to the drugs or non-adherence. And not always we have the tools to know which is the difference, but it's really important. In one case, the drug is working and non-adherence. In another case, the work is not working. So it is a very big problem. Some years ago, our group tried to explore the literature data regarding the tools that all the studies adopted and used in terms of exploration of adherence to treatment. And our question was, which kind of tools the researchers are using in explore adherence to treatment. And as you know, you can see from the table, there are a lot of data, not so many, but a lot of data compared to the other disease for lupus patients. Some data for Behçet disease and few data as well for systemic sclerosis. But the main message of this approach that we use in the systematic literature review is that the main message that the tools used to assess adherence are valid, useful, but very, very heterogeneous. We have some tools, as you can see from the table, the papers that explored adherence to treatment in lupus use the Morisky tool. Morisky is a tool that with few questions may explore if a patient is adherent or not, and if the adherence to treatment, the low adherence is intentional or unintentional, but does not explore why the patient is not adherent. Or combined mechanism of blood samples, hydroxychloroquine dosage questionnaire, self-reported questionnaire, blood test. And as you can see, there are heterogeneous approach, but also heterogeneous results, since in these papers, 26 papers, the adherence rate ranged from 28 to 86. So very interesting, but very heterogeneous. The same thing for Behçet disease and systemic sclerosis, very few papers. And again, the adherence rate was very heterogeneous and probably related to the different approach, since Morisky has an approach, self-reported the questionnaire has an approach, the interpretation and analysis of this data has a different approach. So the main message is we have some data, main data for lupus investigated, but we have very heterogeneous data on adherence to treatment. And the way in which researchers have taken the look at the problem are very different. So from this data, what we have learned and tried to summarize is that the way on how to measure treatment adherence are very different, but we may distinguish in something subjective, something semi-objective, and something very objective. This is the case, for example, of drug level, let's say the blood test. This is the case of hydroxychloroquine, for example. And in many cases, and as you can see, reported by a group from France, there are a lot of data regarding hydroxychloroquine in lupus, regarding the blood concentrations that may reveal severe non-adherence, but also a combination of blood test and also approach by tools, specific validated tools, such as Morisky tool. And the results of this study are finalizing the message that a combined approach is needed. Also in terms of different approach to the blood test, since in many cases, Nathalie Costedois explored in a study if we have blood test or we have serum hydroxychloroquine levels may be considered also, can also be used. So there are different need approach in terms of research in order to try to define if we need blood test plus something else, self-reported questionnaire or validated test, and in terms of blood test, also specific different approach that we may use in order to know if the patient is adherent or not. Just an example from vasculitis, since it is important to share with practice. Few years ago, we explored adherence to treatment also in Behçet. It is a connective tissue disease, not covered by ERN, but many aspects are very similar to our connective tissue disease. And we try to highlight the different profile of adherence to treatment with a specific approach together with a group from Scuola Superiore Sant'Anna, something called latent close analysis, just to try to profile if there is a specific profile of patients not adherent. We discussed this approach, the questionnaire itself, in a co-design approach with clinicians, health economics, patients, and caregivers, and it is really important. And what we found is that, yes, something very heterogeneous regarding also compared the other cohorts, but it seems that the less adherent patient profile seems to be related with being in the third decade of life, and with being diagnosed for more than 5 years. And some consideration related to this analysis that can be, in my opinion, applied also to other disease, that in many cases, patients with a long history of disease may perceive themselves to be able to manage the therapy. And on the other hand, tend to be prone to modify their treatment without clinical consultations. In other terms, they tend to be less adherent. And it is defined as a sort of a little ability of managed therapy that in many cases reported in the literature, also in a high prevalence disease, not only connective tissue disease, is related to the long period from the diagnosis, a long history of disease, and a long experience in managed therapy. And I think it is quite interesting, since if we have to improve adherence to treatment, we have to take into consideration also these aspects. But we know that in connective tissue disease, especially in connective tissue disease, but in general, in chronic disease, adherence to treatment is really a complex issue. And it is a complex issue for all the stakeholders. It is not a complex issue also for patients or for caregivers. But we have to say that it is a complex issue also for clinicians and all the stakeholders that take care of the problem of the disease. And I cannot find a picture that can summarize these concepts, the complex of something that we know that there is present, but in many cases we avoid, for many reasons, to discuss about this problem, this picture. Since in many cases, adherence to treatment for the clinician, for the patient, it's like an elephant in the room. We know that there is a big elephant, but in many cases we avoid to discuss. And this is one of the first barriers of approaching to adherence to treatment, and specifically in improving adherence to treatment. We know that there are a lot of data regarding patient empowerment in improving adherence to treatment, but as we discussed in previous experience, previous workshop related to vasculitis, but also connective tissue disease in our center, we know that, first of all, sharing a therapeutic decision-making process is really, really important, fundamental, essential, since we are talking about something that we as clinicians are prescribed to a person that should take, and it is important to share the route of administration, all the dimension that a person may have in his her life. So it is really important. But sharing the therapeutic decision-making process means also talk about communication. Therefore, patient-clinician communication is really, really important. But another point that it is mandatory to be considered for our connective tissue disease when prescribed or when monitor the therapy, the immunosuppressive therapy that patients take and clinicians prescribe, is try to educate also to the self-management. Self-management does not mean that a patient can be stopped the therapy for different reasons, but it means that patients can stop the therapy when there is a specific indication. For example, when taking immunosuppressive therapy and infections or surgery, it is mandatory for the clinician to explain these aspects and to educate. But education is another key word in patients' empowerment. Education not only on the therapy, but first of all on the disease, explaining from the educational point of view that our connective tissue disease are characterized by a relapsing and remitting course is important in order to highlight how important the drug is to maintain remission. It is also important to highlight how patients' organization and federations are in improve patients' empowerment. And again, patients' empowerment is strictly related also to adherence to treatment. And at least, but not last, it is really, really important to take into consideration in this process the caregiver, since in many cases we know that the administration of a drug and the management of some side effects is important for the caregiver that has, in many cases, as caregiver, by definition, the responsibility to manage, in many cases, the problem. So it is really important. But it is also important to conduct research on adherence treatment, since we know that there are a lot of heterogeneous data from the literature, and we know as European Reference Network, as other networks, as different units, we know that it is really important to explore, to improve the research on these aspects and try to find something that can be related to specific actions that we have to plan in order to improve adherence to treatment in connective tissue disease. But when focusing the attention on research, we have always to focus on which disease, which aspects of the disease we are exploring for, and which is the specific aspects that we are looking for. For example, adherence in pregnancy, in lupus, there are a few data regarding this, but not a lot. So we need many data. We need a lot of data regarding the rarest diseases, since there is another important problem associated and the lacking and few data in the literature regarding the rarest disease in the connective tissue field and how to approach to this problem. Blood tests, there are self-reported questionnaires, there are validated tests as Maurice, there are a lot of other tools, but probably what is needed is a multidimensional approach. It's always better to take a look at something that is by definition multidimensional, and it is really important. And again, just to share a good practice from vasculitis, there are studies, there is also studies that is exploring adherence to treatment, not in terms of how is the prevalence of adherence to treatment, but let's try together, patients, clinicians, and different stakeholders, to design a specific tool together with patients for exploring this. But it is really important as an aspect, as an approach for all the connective tissue disease. But in practice, what can we do for address and improve adherence to treatment with our patients? And this is the slide of the 5 key points that I introduced in the first part of the presentation. Try to leave to you practical suggestions that as patients and as clinicians we should follow. First of all, it is important to discuss about adherence is something fighting against the concepts of the elephant in the room, and we need to discuss about adherence. Otherwise, we are taking a drug as patients, we are prescribing a drug as clinicians, but if we are not talking about how a patient can be adherent, it's something that is very, very limited. But after discussing and assessing adherence to treatment, it's really important to monitor adherence to treatment during the follow-up. And again, discuss in a different evaluation, in a different consultation, if there is a specific problem in not taking a specific drug, since changing the approach to the therapy is not only related to side effects or not efficacy or partial efficacy, in many cases can be also related to challenges for the patients to take the drug, and it is really important. Another important aspect, again, to summarize, is a very trust relationship, since prescribe a drug is related to a sort of empathy relationship, but is related also to education and educate on the disease, educate on overcome the fear of feeling judged. It is really important. Otherwise, we cannot discuss about adherence to treatment, and we cannot monitor adherence to treatment. And again, education not only of the patients, but also of the caregiver. And I would like to highlight that it is important for improving adherence to treatment, educate not only for the drug, for the side effects, for potential side effects, but educate on the disease, on the characteristics of the disease, since we are talking about connective tissue disease, which are chronic disease. It is really important. And finally, checking. I think it is really important in improving adherence to treatment, since if we discuss about adherence, if we try to improve adherence, to find a way to choose a therapy in a way that the patients can do at home, and we do not check if the information, all the information regarding the disease and the drug are captured by the patient, we cannot talk again or discuss about adherence to treatment. So check in any case if all the explanation and information have been captured from the patients and the caregiver. So finally, just to leave to you some very basic take-home messages, treatment adherence is fundamental, is a key for treatment in connective tissue disease. Connective tissue disease are very challenging disease, and we have a lot of problem in the diagnosis, in the early diagnosis, and in the approach to treatment in the different countries, as ERN are suggesting in the approach of the cross-border also care. And if we not consider as a key, as something crucial for the treatment, we are performing something wrong in the treatment approach. But we have to improve adherence to treatment, since, yes, there is an elephant in the room, but we may talk about the elephant and we may also improve, but we should improve also in a multidimensional approach. Otherwise, we take a look at the problem only on one side, and it is not correct in very challenging disease as connective tissue disease, and with a very challenging problem as the adherence to treatment. And finally, patient empowerment is really, really important, not only for educate patients and to be aware of the disease and the importance of take a drug, but also for address adherence, since it is important to, as the example of Bechet, it is important to discuss with the actors, patients and caregiver on how to look at the problem. So try to define different dimensions together with the actor, with the patients and caregiver, and try to improve treatment adherence. And I will leave you with this final slide, since I think that these 5 key points may help us in clinical practice, both clinicians and patients. Thank you.